Dr. Tania Bruno is a full-time neuro-physiatrist and director of EMG at the University Health Network's Toronto Rehab Institute. Dr. Bruno's practice is chiefly divided between electrodiagnosis and MS rehabilitation, and since 2010, Dr. Bruno has been dedicating herself to optimizing symptoms and maximizing functional independence in persons with MS. Dr. Bruno's interests extend to research collaboration in the field of MS rehab as a whole, exercise, rehabilitation, and advocacy for persons suffering from chronic and episodic illnesses. Now, did anybody in this room other than a few of us know that Dr. Dale Robinson is Dr. Tania Bruno's husband? And last night, there was their anniversary. So we are thrilled that the two of them are here presenting together. So Dr. Robinson graduated from Dalhousie University Medical School, trained as a neurologist at McGill University, and worked as a neurologist for more than 20 years in the Maritimes and 3 years in Toronto. You can ask him why he moved to Toronto. Dr. Robinson is a general neurologist with specific interest in MS and how do you say that? Well, Botox, I'm just going to say treatment. Botulinum, I should say that, for spasticity and other problems. And Dr. Robinson is based at Markham Stouffville Hospital. Now, the two of them will be tag-teaming their presentations, so they'll be going back and forth with their slides. We will take a break midway or so, around 3-ish, depending on our timing at this point. And again, when it comes to Q&A, I ask that your questions are for the whole room, not specific to your own medical conditions. And I look forward to hearing from the both of you. Thank you. Two glasses of water. That's great. That's great.
Well, I think I can speak for both of us in saying that we find it an enormous privilege to have been invited to give this topic today. And we're really hopeful that you will stay engaged and participate. We won't make it directly interactive while we're doing the talk, except for a few bits here and there. But we certainly will stick around to answer any and all questions that is within our scope of knowledge. If we don't know, we will definitely tell you we don't know. And yes, thank you very much. And I have to add another little tidbit of information, personal information, because it is kind of cute. This is probably the exact room that my parents celebrated their wedding celebration back in 1971. So I wasn't present at that time, I can tell you that. I wasn't born in 1971, but yeah, that's special. So we're really hoping that this can be a guide to what is a very, very complex problem, and that you'll take away something that can actually impact your very own health care by the end of this talk. I've put up some of my disclosures. I won't go through each and every bullet point here, but suffice it to say, I do not perceive there to be any bias or conflict of interest in the information that I am going to present to you today. And we'll hand over the mic to my husband, Dr. Robinson, and he'll say a few words of intro.
Okay. Thanks, Tania. Thanks, everybody, very much for the invitation. And I echo what Dr. Bruno, you called me your husband, but we wondered what to call each other because we haven't done this before, so I hope you bear with us. We've done it independently, but never together. I have a small correction. I don't have any other disclosures than what you see either, except that there's a small correction. I've been in Toronto 5 years, so yesterday was the 5th anniversary, and this seems to be what is now passing for a date, which I think is a bit sad. But with that said, we'll move on.
I'm going to add one other thing, because I'm not sure.
Is this going to be live?
No, I just wanted people to know, because there may be a few familiar faces in the audience, that Dr. Robinson also spends some time at the St. Mike's MS Clinic, and he's been doing that for a number of years now. So MS really is one of the things that he likes to specialize in. So I want to go through the objectives, and I'm hoping that all of the audience members, by the end of this talk, will at least be able to have a sense of what is the difference between acute pain and chronic pain, and specifically as it pertains to MS, and to recognize the various treatment options for nerve-generated pain versus pain generated from other bodily structures. And that would be drug treatments as well as non-drug treatments. And then also to have a few resources in your back pocket on where to go next, depending on your own personal situation. So that's the intent of this talk. And then above and beyond an intent, I am hoping that we help facilitate an ultimate purpose, and that's really to empower persons living with MS and caregivers, if that's applicable, to co-manage symptoms, really take ownership and be an advocate for yourself in your own medical care. And this would not be strictly limited to pain, but any symptom and any issue related to function, and to eventually be on that path to achieving the highest possible quality of life. And I'm also hoping that the two of us will be able to motivate persons living with MS and their carers, if applicable, to take at least one action step in relation to feeling better and doing more where it pertains specifically to pain as part of this talk. So, you know, if we can get some knowledge out there, fantastic, but the goal would be behavioral change. And that's a tall order, but that's the whole purpose of presenting all this information. So used to clicking on the computer. We're going to go through some basic definitions. Dr. Robinson is going to spend a bit of time enlightening you on the neuroanatomy involved in pain pathways. He'll talk about epidemiology as well. And then we'll talk, the two of us together, about different pain syndromes common to MS patients and some classification systems in regards to how to define pain in MS. And then, of course, spend time on treatment. Obviously, that's going to be the key take-home points. So the International Association for the Study of Pain has defined pain for research purposes as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such. And that's really important. There's two very important key things with this definition, and that's why I've put it here on the slide. First of all, pain can be emotional. It's not just a sensory phenomenon. And there's sort of a back and forth between those two domains. Then the other thing is that most of us are hardwired. We are evolutionarily programmed to perceive pain as a warning to something going wrong that we need to prevent from getting worse. So we see it as, oh my gosh, something's happening to a body part. If it hurts, there's got to be something wrong with that specific area that we perceive that hurts, and possibly the tissue is damaging, right? So it's a strain, or it's a sprain, or it's a break, or it's a bruise. And that is actually not necessarily true. And therein lies a really big divide between acute pain and chronic pain, as you'll see. They also devised an extremely lengthy taxonomy, and what does that even mean? Well, they list all different kinds of ways to describe the actual experiences of pain and to classify them. And that's beyond the scope of our talk today, but I'm trying to hit home the point that pain is no easy thing. Pain is a hard thing, not only to deal with, but to actually research, learn about, understand, and move forward in trying to correct. A lot of you will have heard the terminology acute versus chronic. There's a big debate amongst clinicians and amongst researchers about how you make that determination. And for most people, acute would be within the first 6 weeks of having that pain. In some circles, that might be pushed up in towards the 3-month range. But if you say the first 6 weeks of when it starts, that's acute pain. Anything that goes well beyond that, and especially if it goes on beyond 3 months, that's when it's entered chronicity. It's taking on a life of its own, and it becomes, in many ways, an independent impairment. And then, of course, pain, we all know, can be constant. They're 24/7 and interfering with your sleep, or it can be intermittent, or it can even be paroxysmal, whereby it is so unpredictable, and when it comes with a vengeance. Then it can be described in terms such as burning, shooting, stabbing, electric shock like, pins and needles, throbbing, achy, dull. And when you're telling your doctors about the pain that you're experiencing, it would be really helpful to go into that encounter having a good idea of how you're going to describe the discomfort, because depending on how you describe the discomfort, it already lets your physician understand which kind of pathway to take in his or her own brain in terms of trying to sort out where that pain is coming from, what that pain means, and how best to treat it. More often than not, things that are burning, shooting, stabbing actually have an underlying nerve origin, whereas things that are dull or achy, they tend to come from other bodily structures. I mean, ultimately, as Dr. Robinson will talk to you about later, all pain is eventually carried as per nerve signals, but the actual localization of the pain generator is important, very important in terms of getting to the bottom of how to fix it, and so describing it properly would be important. So we've already gone through acute and chronic, and I want to tell you about this term, central sensitization. Persons in the audience who may have seen me in clinic before may have heard me talk about this because it's super important. You've all probably heard about neuroplasticity and how you can change your brain. That's actually quite a good thing, because you can, with enough motivation and a number of different strategies, change your brain for the good. But unfortunately, the way we're set up is that we can actually change our brain for the bad. And in terms of central sensitization, it develops when there is chronicity in that pain generator impulse, and the signal is delivered, and then it's delivered again, and that signal alone changes the hardwiring inside the brain and the spinal cord, and it makes that system much more excitable and at the ready to respond to any little input, whether that input is noxious, AKA should be perceived as a threat or damaging, or not. And so that's going to become important when we talk about a few other things in a moment. So before I hand the baton to Dr. Robinson, I just want to highlight the fact that we know, and researchers know, and this is a very avid field of study, that pain is not just subjective and real, but it's extremely complex, and it is influenced by your genetic makeup, your culture and your beliefs, your mood, stress, whether it be physical or psychological, your sleep quality, and your overall level of fatigue. And in terms of an underlying disorder, MS is greatly associated with fatigue, as many of you might have experienced. So pain in MS is even that more of a I don't know if this is too strong a word, but of a beast, And now I'll hand over the baton.
Thank you. So, not to prolong the introductions, but we also have not been to each other's talks. So I enjoyed that, and it's just the introduction. I was a bit worried about Mark Friedman being a tough act to follow, but this is even tougher. So just in a few slides, I wanted to go over the basics of neuroanatomy. So we have a little cartoon of a person who looks like they've done something to their foot, maybe stubbed their toe. And so down, he's sitting and he's holding his toe, and down at that level, we would be in the peripheral nervous system. So multiple sclerosis, as you well know, involves the central nervous system, the brain and the spinal cord, but the first sensation would come from a different part of the whole pain pathway, the peripheral nerve. And that impulse, that response to the pain would come in and climb up, in this instance, through the leg and through the hip and into the spinal cord at the dorsal root ganglion. So that's near the bottom of the spinal cord because it's coming from the foot. And every level coming up the spine has dorsal root ganglia where the nerves for that respective area of the body come in. And they all climb up the spinal cord and pass through the brainstem. The brainstem is the connection between the spinal cord and the brain. It's, sorry if that's too simple. I know that this is quite a sophisticated audience. And then passes from the brainstem up to the brain. So in the brain, it's too small to see in the cartoon, but in the brain, when you think of the gray matter, the wrinkly part of the surface of the brain, the sensation is served by the somatosensory cortex. But that's only sort of one stop. And this is only showing one nerve with connection to the next in the chain going up to that area. And really you have to think of the pain pathway as branching out a lot from there. So it's more than just a pathway from point A to point B. It sort of gets to point B, but then it's part of a matrix, a real interconnection. And though that sort of array of nerve connections that includes other parts of the brain, the insula, the cingulate, the prefrontal, the thalamus is an important sort of relay station. All of those things sort of light up when there's been an activation by pain. And those things are what are giving the meanings and the feelings that go with the pain. When you go back to the definition that Dr. Bruno talked about, it wasn't just the sensation, was it? There's an experience that goes with pain. And so a lot of the brain is actually involved in that. There's a simpler cartoon just with sort of a box diagram. I won't go through it in detail, but you can break it down into sort of those simpler relay stations along the way. But the main point is what is not on the slide, and that is that complex array of connections at the level of the brain. Neuropathic pain, you often hear that term, neuropathic pain, is pain that is caused by a problem in that pain pathway. So then you might not have the actual stimulus of stubbing your toe anymore, but that pathway has been activated from stubbing the toe, and maybe that's not a serious enough example, but something that keeps that pathway active and keeps that matrix active. And then I can show that better with this diagram, my last neuroanatomy diagram. Do you guys know this guy, this representative, this very ill-formed person called the homunculus? One side has to do with movement, called the motor side, and that's more toward the front of the brain. I think if I just use this pointer, toward the front of the brain, whereas the pink is toward the back part of the brain. And the pink is more, I'm sorry, I have it reversed. The pink motor and the sensory more toward the back of the brain is to do with the sensation. And the size of the man's face, of the thumb here, of the hand, going down to the trunk, the leg, the genitals are there as well. The size of those things has to do with the size of the cortex that is taken up with serving those feelings. So we're very complicated people, complicated animals, and so a lot of sensory cortex is taken up in this example by the face. Or let me show you the thumb again, and then come down to the toe, and I can point to the other side too for the other side of the room. Well, maybe I can't. Sorry about that. I think I did. So, you know what? That's too far away for the pointer. I'm going to stick with this side. I can't see it over there. Oh, yes. No, I'm sorry. I can't see it over there. I'm going to have to stick with this side. So in my example, the guy that stubbed his toe, the toe is very small on that diagram, whichever side you're looking at, whereas the thumb is very big. And so if you think of that activated matrix, maybe now even after the stimulus for the pain is gone, the matrix is big enough so that the area of the brain involved, let's just imagine it's more the size that should be taken up for the thumb in that diagram, not for the toe. And so you've got a problem there. You've got a mismatch. You don't have the acute problem causing the pain, for which there are treatments. you have a problem that's neuropathic pain inside the system, which can be harder to treat. I see some heads nodding, so I hope that that's some help in understanding that. So this sort of summarizes what I've just said, that once the pain reaches the conscious awareness level, multiple neural networks are activated. So now the matrix, not just point A to point B, but the matrix is activated, and that they can stay activated, and that pain that's ongoing can reinforce that matrix, sort of keep it big and robust when we really don't want it to be. And this is the neuroplasticity that Dr. Bruno spoke of. This is the neuroplasticity in her slide gone wrong. And we want to try and reverse that problem. So the foundation of the sort of overall holistic approach to treatment is to reduce the true pain generator, in this guy, the whatever caused the pain in the foot. So eliminate that noxious stimulus, but also dampen down the overactivated matrix. And that's the trick, if you want, of trying to treat the neuropathic component of the pain, which is usually the chronic pain. So to switch gears from the anatomy to epidemiology. Epidemiology always put me to sleep in medical school. I hope that does not happen here. Pain is worthy of so many people being in the room. Pain is very, very common in multiple sclerosis. There are a number of numbers there which I won't read for you, but suffice it to say that at least half of the people in the room with MS are suffering some sort of pain. Prevalence means at any time when we look, and the people that that have MS at any point along the way of MS, over 50% will have pain at some point. Down at the bottom, this is a slide done by Dr. Bruno, and she has referenced Dr. O'Connor. That, just to point out, that's not Dr. Paul O'Connor that was working in the MS clinic at St. Mike's, where I work part-time, but a different Dr. O'Connor. But I did reference Dr. O'Connor's book as well, and he estimated 20 to 50%, and I think it's more likely the higher number, in the 50% range. When you study pain across the population of multiple sclerosis, you see higher amounts of pain, moderate to severe pain, than in the general population. So you're comparing a group with multiple sclerosis with roughly the same age, and it's matched for how many men, how many women, higher incidence of pain in MS, higher use of analgesics, and a higher likelihood of some dysfunction, some disability from the pain. 3 out of 4 studies in a pain questionnaire asked to score pain showed that it was higher in MS than in age and sex match controls. There is one group of patients in studies that have a little bit more pain than the MS population, and that's spinal cord injury, SCI. But of course we know that many with multiple sclerosis may have spinal cord involvement, and so that's sort of a double hit. Nursing home patients with MS are more likely to have pain than residents in a home that don't have MS. And the quality of life is reduced by having the chronic pain in MS. So a little bit of a quiz. Which of the following is not associated with a higher likelihood of pain in MS? Would it be having an older age, a higher expanded disability status score? Would it be female sex, having MS for a longer period of time, or having progressive MS? Maybe I could see a show of hands for A. B. C. See some hands for C. D. Longer duration. And how about whether it's progressive? It's no longer relapsing or remitting, but progressive. Okay, so there was a fair number of votes scattered for the last three choices. The actual answer is C, that the pain is not of a different incidence in men or women, so equally affected. And I think if there was any trick to this question, it might be answered in the next slide, which talks about the severity of the pain. So not whether you have pain or not, but the severity of the pain. And the severity does tend to be higher in women. So maybe that's what some people were thinking of. It's greater pain severity when there is increased disability at higher age, if there's depression, if there are other things going on, a lower education level, if the pain has been there for longer, and people that access the healthcare system tend to have greater pain severity. Everybody's still awake after the epidemiology section? That's fantastic. So we have a few slides on how to classify pain. So the first of these is a little bit more complicated than the second. I will try not to get too bogged down in it, but it's mainly to mention the word neuropathic again, which we've gone over. So the first in this classification is neuropathic pain related to MS, or pain that's indirectly related to MS, pains that can be related to MS therapies, and then in this reference, Dr. Pullman talks about pain as the last category, not related to MS. I think it's simpler, and I know Dr. Bruno agrees, to just think of it as primary pain, so that would be more directly related to MS, secondary pain that we see in people with MS, and then comorbid pain. So something that doesn't, it's not directly related or even indirectly related to multiple sclerosis, but a pain that's there for another reason. Say someone that has migraine as well as MS. But we'll talk about examples a little bit further. So I was going to say a few more words about primary pain, and then Dr. Bruno was going to talk about secondary and comorbid in a few minutes, in case you were wondering when she was coming back. I can't tell how much time is going by as I stand here.
You're doing good.
Okay. So pain directly, this is the primary category, pain directly related. So just to give the examples and not flesh it out too much, because I'm going to do that in a minute. Optic neuritis, people have probably already read ahead of me, trigeminal neuralgia, Lermite's phenomenon, the painful spasms like the MS hug that people talk about, or some sort of dysesthetic disturbances. So in the sensory, painful sensory symptoms that can be in the trunk or in a limb, usually in the distal part of the limb. And if you look at any time in people with multiple sclerosis, along that somatosensory pathway, and this would be the central part, not the peripheral nerve, although that can be involved, but we're talking more about the central nervous system in MS. Over a quarter of people, 27.5%, have some lesion in the myelin along that pathway. So that's not a surprise to us because we talked about how common pain is. Secondary pain is going to be more Dr. Bruno, but just to mention, this is, if you think of someone, because of their MS, they're having difficulty walking, and that could lead to a secondary problem. So because they're walking in an unusual way, they might have low back pain. Well, the low back pain is not directly from the MS, but it's a secondary pain. And again, Dr. Bruno will talk more about that. And I've already mentioned the example of migraine for comorbid illnesses, migraine along with MS. You can have pain associated with other illnesses as well. So inflammatory or degenerative arthritis, a peripheral neuropathy, you could have a kidney stone, that's renal colic, and those things aren't caused by MS, but of course could be seen in someone with MS. So just a few words on each of the examples for primary MS pain. Optic neuritis is a very common symptom of multiple sclerosis. It's a little bit controversial as to whether most people or how many people with optic neuritis actually have pain. But the way I was always taught, and certainly I see it very frequently, is when you have a vision loss that is painful, particularly pain on moving the eyes, that's the hallmark of optic neuritis. But you can also have a pain that is sort of a more dull pain that is behind the eye, not changed with movements. That's sort of a dull or achy pain. But the more characteristic one, I think, is the vision loss of optic neuritis, which I'm not going to talk too much about because that's not the focus here. But the pain when we ask a person in the office to follow your finger to move the eyes, or the person comes in saying when they track something, when they watch a bird flying, it's painful when they move their eyes. Trigeminal neuralgia is something that's quite common in multiple sclerosis. So compared to the general population without MS, trigeminal neuralgia is seen about 20 times more. And if you look at just people with multiple sclerosis, the prevalence or the number at any time that have trigeminal neuralgia in an MS population is between 2 and 5%. So it's very common. I was reminded of this in my reading for this presentation that, and I'm going to remember this in the office, that when I see someone who's less than 45 is presenting with trigeminal neuralgia, that there's an increased chance that that's from multiple sclerosis. So of course we see trigeminal neuralgia very frequently, and it doesn't have to be associated with multiple sclerosis, but in a younger person, and here young is defined as less than 45, some could argue with that, we want to think more about multiple sclerosis, maybe not just from that single event, that might be a clinically isolated syndrome, but that something more is going to show up down the road. Trigeminal neuralgia is what some also know as tic douloureux, a painful tic. And it's felt to be a lesion in this somatosensory pathway that we talked about that's very close to where the trigeminal nerve, that there are 3 branches for 3 branches of the face, come into the brainstem. That's where we see the area. It can be difficult to treat, but we do have multiple treatments, and we'll talk about those a little later on. Lermite's phenomenon. Lermite's phenomenon, many would know in this room, is when you bend the neck, you're giving sort of a mechanical perturbance or disturbance to the axons, and if they're injured because they've been stripped of their myelin, you can get this false transmission where different parts of the nerve are triggered to give an impulse that gives a tingling type pain going down the neck, and it's very common that it goes further down to the back, and people will sometimes even tell you that they feel it in the distal limbs, the fingers or the toes. It's usually a very brief sensation, and it's usually quite predictable that the person has noticed it on their own, and they come into the office and they say, you know, doctor, I feel it when I do this. It's usually, the last point there, that it may be associated with the posterior columns. That's at the back part of the spinal cord. The painful tonic spasms, this is a type of dystonia. So the muscles in the typical MS hug that people will talk about has to do with the muscles that are between the ribs, the intercostal muscles go into spasm and give that squeezing or tightening feeling, the so-called hug of MS. It's usually brief and it can occur many times a day. Sometimes there's a tingling or other sort of sensory feeling before the spasm actually comes. Oftentimes it can be a whole limb, so it'll be triggered by movement. So maybe a transfer from a chair to a bed, and the whole leg will be very rigid, very dystonic, which can last minutes and is very uncomfortable, as you can imagine. Hyperventilation can also bring it out as well. One of the tricks, you heard I'm a general neurologist, so I see a lot of people with seizures as well. And one of the things with seizures, even when we do the brainwave test to look for seizures, we'll get patients to hyperventilate. So they breathe rapidly, and that can sometimes trigger a seizure. So that was a little bit confusing with this for a while, because hyperventilation can trigger these spasms, but they're not a form of epilepsy. So you can have the EEG wires in place and someone goes into one of these spasms after hyperventilating or not, and it doesn't show any epilepsy. And the other key to that is, because many people would know of seizures in this room, is that it's also not a seizure because the people do not change their awareness. They don't go unconscious. They're not in a daze, or they're not postictal afterwards. The last slide on primary MS pain really is just to name some other parts of the brain to reinforce that idea that we're not just talking going from the stub toe up to the somatosensory cortex, not A to B, but that matrix. And when that matrix is involved in a pathological way, in an abnormal way, it's often because we're getting crosstalk between the different nerves. And this is, at the bottom of this slide, what's referred to as ephaptic spread or ephaptic transmission. So the shock or the electrical impulse that's traveling in the nerve is supposed to be contained in the nerve. And here, my professors never liked when people talked about the nervous system as wires with plastic coating, but we always tend to go back to that and talk about a nerve that way. So you have electrical impulses in a wire, but you can, if you're careful, touch the wire that's got the coating around it and you won't hurt yourself. But if that plastic coating, in this case myelin in the example, is stripped off, and now nerves beside each other can trigger each other. Now the electrical stimulus is not just running down that wire, it's bouncing back and forth between wires. That's that crosstalk of ephaptic transmission, and that's very important in understanding neuropathic pain. So I survived my first part standing up. I'm going to turn it over again and take some water.
So when we talk about secondary MS pain, overwhelmingly it's musculoskeletal. And that term references bones, ligaments, tendons, and muscles, and the joint spaces between two bones. And this is very well recognized, but unfortunately doesn't garner a lot of specific investigation in the field of MS research. But out of all of them, low back pain is best described. Maybe it's best described also because low back pain is so prevalent in all of humanity, regardless of whether a person has MS or not. The prevalences are higher than for something like trigeminal neuralgia, which you heard Dr. Robinson speak about. And we're looking here at about 10 to 16%. But the hallmark of back problems is this, that the natural history is that it waxes and it wanes. And one of the things you have to know about the back is that the setup anatomically is such that it's very dependent on the lines of force that are transmitted through the skeleton. Our bone remodels with lines of force. And so if you are putting lines of force through the skeleton in ways that are not in an ideal posture, you may get some bony overgrowth where you don't want it to happen. And as we all age, whether we have MS or not, there are certain things that happen to our skeleton and happen to the musculoskeletal structures of their own accord, which are hard to reverse. And those are things that are genetically predetermined and just simply part of being constantly in an anti-gravity position for most of one's life. And that includes things like drying out of the disc spaces. And so when you dry out those spongy, shock-absorbent parts of your spine, then suddenly there's a positive feedback cycle, and you get more and more abnormality in terms of the stresses that go through. So any one of those structures can be the source of discomfort. Also, Dr. Robinson referenced, when a person with MS may start to have mobility impairments and may be putting abnormal stresses while they're up and walking around. Well, there's also abnormal stresses that can occur when someone is seated in a chair all day. And so proper seating is absolutely critical to helping to manage some of these secondary musculoskeletal issues. Now, what I've been talking about is what we call mechanical pain. Mechanical pain is usually heralded by pain with movement and varying postures or stresses on the structures I just talked about. But there can also be central pain. And ultimately, and part of what I hope is going to be a take-home point for each and every one of you in this room is that it doesn't matter what is the original source of pain. Doesn't matter if it's a joint, doesn't matter if it's a bone, doesn't matter if it's a tendon or an internal organ like the bladder. Those sensations are all carried through the pathways Dr. Robinson referenced. And so ultimately all pain is neuropathic pain to a certain degree. And in MS, because those pain pathways themselves may be deranged because of demyelination or actually loss of the actual nerve tract over time, then you get this very complex interrelationship between what has become a secondary problem impacting the primary problem, and vice versa. So along with headache, which each and every one of us in this room has experienced, back pain is something that is ubiquitous and very, very common. We also experience in MS and out of MS muscle achy pain. And that can be also in the context of nothing particularly wrong with the muscle, but it's overused. It's compensating. So for example, let's say, your right upper limb doesn't work so well, or maybe it's affected by spasticity and it's stiff and it's not the go-to limb to use. Maybe you're doing everything with the left. If you're doing everything with the left over and over again, you're doing all your heavy lifting, you're not sharing with bimanual tasks, it's quite possible that you're going to tire that muscle out and you might get achy soreness. So there's lots and lots and lots of reasons why not being able to do what you were normally used to doing as a result of your MS lesions creates additional problems, and so on and so forth. So other things that are implicated, not just postural dynamics and alterations in forces across body parts, but it's the inherent weakness and what can happen with overuse. There's spasticity. Spasticity in and of itself can be uncomfortable. Balance impairments can also not just lead to problems with how a person walks, but can lead to falls. What happens with a fall? Well, hopefully only a minor bruise or a scrape, hopefully not even a cut. But sometimes falls can be absolutely deadly. And so depending on where the fall takes place, how the fall happens, you might have everything from a concussion insult all the way to a broken hip. And each and all those body parts that gets injured has their own set of pain receptors that are feeding into that pain matrix that Dr. Robinson talked about. So if we look at how common these things are in a community-based retrospective cross-sectional design study, which is looking back at a group of people, and they had actually a very large study sample size for this, about 477 persons. About 58% had experienced a fall in the preceding half year, and 52% of those falls were medically injurious. Now, I am not going to object to being labeled a broken record, but I'm going to encourage you to all remember that falls are completely hopefully avoidable and unwanted complication of MS. We don't want them to happen. We never want them to happen. And sometimes in order to make them not happen, things have to happen around the area that might otherwise have been the location of the fall. So there needs to be environmental adjustments, so safety assessments and modification of how a person's home is laid out, maybe having some adaptive aids to make sure that the balance is corrected, maybe going all the way to using a brace to correct for limb weakness. So there are a lot of steps in trying to get that falls risk reduced. And I'm going to show a slide that I love to show, and I love to show it to my learners because it is so visual and it takes the message home. And again, I'm going to be a broken record. I'm going to say it now and I'm going to show you the slide later. But to be your best with MS means to be able to compensate maximally for all your lesion load and your deficits. And in order to compensate best in MS, you need to be at your best in every single body system. And in order to be your best at every single body system, you have to reduce abnormalities in all those systems. So don't fall. I don't want anyone here to fall. The unfortunate thing is, in addition to having that higher risk of falls when there's mobility impairment or during a transfer if you're even non-ambulatory, has to do with the fact there's an increased risk of osteoporosis or bone density loss due to MS itself. And this is very complex. There are many different things that go into increasing osteoporotic risk. Some of it has to do with genetics. Some of it has to do with faulty vitamin D metabolism or low vitamin D exposure. Some has to do with nutritional, some has to do with exposures to steroids, which leach the bones of calcium. I mean, there are several other factors too. But when you have fragility in your bones and you take what would otherwise seem to be a harmless trip or fall, suddenly you can end up having a very substantial injury that you wouldn't have predicted. And another piece of information that is not on this slide, and I don't think it's on the next slide either, but I'm hoping that it'll leave an impact, is that a hip fracture has a 20 to 30% all-comers mortality at 1 year. Now, true, this is not just an MS statistic, and this is taking all comers. This is your 18-year-old with a high-velocity motor vehicle collision, your 95-year-old person who's fallen out of bed. You take everybody, and because of where that fracture actually occurs, what's in the bone marrow, what happens with the complications of immobility, what happens in terms of surgical correction, what happens in the context of sort of being bedbound and deconditioned as a result, by the end of the year, a lot of people who've had a fracture are no longer with us. So it's very critical that bone density be looked at. If you haven't had a bone densitometry and you are having a high falls risk, it's something to ask for. And that's independent of your age. It's independent of whether you're male or you're female. And unfortunately, I can't cite you guidelines for treatment of osteoporosis in MS because they haven't been generated as of yet. So hopefully over time, we'll get those done. So moving forward, I already talked to you about abnormal forces on the bodily structures, which could actually promote inflammation that then becomes a problem in and of itself. You can have these musculoskeletal discomforts really exacerbated by poor sleep and mood disorders, and those are also common in MS as primary MS-related issues. They can also be secondary MS-related issues. So, for example, a primary MS sleep issue would be a derangement in how sleep architecture is actually formed. So sleep architecture refers to, okay, it's going to take me so long to kind of get into sleep, then I'm going to be in a certain stage of sleep, then I'm going to move into the next stage of sleep, I'm going to have some dreams. That can be deranged because of lesions in the brain. And then you can have secondary issues where, the lesions are affecting your bladder and you're up every 2 hours to pee. That's also impacting your sleep. It doesn't matter what the cause is of the sleep derangement, it's going to have an impact on how you perceive pain. So how I describe it to my patients and also to my learners is that the areas that control mood, the areas that control sleep, the areas that control pain, they overlap in terms of neuroanatomy, and they overlap with the neurotransmitters that actually enable one nerve cell to talk with the other nerve cell. So in making a problem in one zone, you end up having problems in other zones and vice versa. And consequently, in treating one thing, you might have a really big improvement in the other domain. The next bullet point is actually a really important bullet point because many of my MS patients, and many MS patients in general, suffer or fulfill criteria for fibromyalgia, which is an old term that has been replaced by chronic widespread pain. And it used to be, in the days when I was in medical school and I was training, that fibromyalgia or chronic widespread pain was the purvey of rheumatologists. So if you had a problem like that, you were always seeing a joint specialist. It's not a joint muscle problem. It's a central nervous system problem. And it's a fundamental derangement in how the pain matrix is behaving. So the reason it's a syndrome is that you can have these derangements in how the pain matrix is behaving, not just in MS, in all kinds of things. And I don't want anyone to take this challenge, but for persons who, say, want to do an experiment and want to deprive themselves of sleep for days on end, dollars to donuts, someone gives you a little light pressure on your upper shoulder, it's gonna hurt, okay? So all of us can have chronic widespread pain given a certain set of circumstances. Now, true, there are some of us that are more predisposed than others. So I'm going to ask, this is the second quiz of the day, which of the following statements concerning fibromyalgia or chronic widespread pain is false? A, fibromyalgia is considered a pain amplification syndrome associated with central sensitization, aka neuropathic pain. B, functional MRI studies demonstrate overactivity of the insula. This is a part of the brain that is integrally involved in deciding what's important to pay attention to and what's irrelevant. So it's kind of like a gatekeeper region. And C, persons with fibromyalgia have decreased sensitivity to light, sound, and smell. And D, hyperalgesia and allodynia. Hyperalgesia, I have to define, is taking something that should be painful, and when you actually apply it to the body, it gives an overwhelming pain. And then allodynia is something that should never cause pain, say a light touch, a cotton swab, and suddenly that's causing pain. And so both of these may be found in otherwise non-painful areas. And I'm not going to take hands for this one because I think this one is a kind of a bit more esoteric, but I'm going to give you the answer. C, persons with fibromyalgia have actually heightened sensitivity to all kinds of stimuli. So it's not just an amplification of touch, pressure. It's an amplification of almost all the sensory inputs that come into the person. I want to call your attention to something called trochanteric bursitis. This is an inflammation that occurs in an area near the hip girdle where you have tight, stiff muscles rubbing on the bony prominence of your femur, which is your hip bone. And when you have tight muscles rubbing over that bone, the body wants to protect itself, and it actually creates a little fluid-filled pocket as a shock absorber. That can be incredibly uncomfortable. And so if you're having struggles like turning over at night, sideline, pain in the hip, there may be a very good effective treatment strategy for that. So bring that up with your caregivers. You could stretch your iliotibial band, which is sort of a connective tissue tract that connects a muscle called the tensor fascia lata all the way down to the knee. You can stretch that. You can stretch your gluteus medius muscle. This is one of the big buttocks muscles that inserts near the trochanter, which is that bony prominence of the hip joint. You can ice massage that area, really press hard and cool the area to decrease local inflammation. You can apply topical anti-inflammatories, you can use oral anti-inflammatories, and that area in itself can be amenable to local corticosteroid injection or deep heat modalities from physiotherapy, so ultrasound, laser, etc. Headache, we've referenced that a number of times, and in dedicated studies looking at MS patients suffering from headaches, tensive headaches or tension-type headaches and migraines are quite common, and again, a 50% prevalence. And there's an association between migraine and MS exacerbation. So for persons who are in the relapsing remitting phase, you may identify with that. It's 3 times more prevalent in MS clinic patients than the general population. I'm not sure we quite understand why. And anything, going back to what I said about keeping every body system in check, any pain generator, any pain problem has the potential of amplifying any other pain problem in MS. So it's all a fine balance. Don't neglect what you think is a non-MS problem when you're with your MS care providers, because in fact, it may be very relevant. It may be something that is amenable to a relatively straightforward treatment approach, and you may be functioning better overall. You may feel stronger, you may have less daytime fatigue, you may feel more alert and lucid. So definitely have that in your back pocket as well. Nothing should sort of be forgotten because, oh, well, I'm with my MS doctor and I don't think this is an MS problem. Bring it up, disclose it. If it's irrelevant, it'll just be, put to the side, but it might very well be relevant. The peripheral nervous system, which is everything outside the spinal cord itself, and the, by convention, anterior horn cells that are located in the spinal cord and give ultimately the signal to the muscle to contract. That can be, also problematic in MS patients. A lot for some secondary problems related to MS, and sometimes patients come in to see me and they have a problem with tingling in their hands. Well, the tingling in the hands might not have anything to do with their MS lesions. Maybe they've developed a carpal tunnel syndrome, or maybe they've developed an ulnar neuropathy at the elbow because they've had their upper forearm on a hard wheelchair armrest for hours and hours per day, and you relieve that, you relieve the discomfort in the hand. So not everything that feels neurologic or is neurologic relates to the brain and the spinal cord. There are other structures, and they are worthy of investigation, and there are plenty of objective tests and physical exam maneuvers that can help tease that out. So just a little bit about comorbid pain. I already talked to you about nerves getting pinched in persons who are wheelchair bound. Just like back pain, mechanical back pain is common, sciatica or pinched nerve roots in the back, that's also very common. And so that also can present as if it were an MS pain problem, but is not an MS pain problem and can be fixed perhaps by a surgical intervention to open things up, give the nerve root more room. There is literature to support that cervical, so the neck, and lumbosacral, low back, decompressive surgery can be safely performed in persons with MS with good results. And actually, I have patients in my own practice that can testify to this bullet point. So once again, know your body, be aware of what you're experiencing, and share it with your care providers. This is the slide that a lot of my residents know because I show it a lot. And it's this house of cards. And for me, MS is a precarious house of cards. And you take one single card out of the stack and the whole stack falls down. And so that's how, in my mind, when I'm hearing someone's concerns, I'm thinking about that house of cards and where I'm putting that concern within the stack, and knowing, how am I going to help keep that in place? Because, I don't know, have any of you played? I used to love to build these things when I was a kid, so it's not because I know about them so much. You can make small little perturbations of each and every one card, and you can actually move things around and things still stay relatively okay, but then just one little millimeter more and it's, fallen down. So very important take-home point. To be at your best living with MS, you have to take control of the care of your whole person. And that would be physical, it would be cognitive, it would be emotional, it would be spiritual. So you want to be at your best in all of those domains to try to be at your best in general in terms of your overall function. And besides my house of cards, I have the representation of a positive feedback cycle. And this is also a very important take-home point for pain. When you have a pain generator, whether it be that you have actually damaged and hurt a part of your body, and that pain signal is going up that pain matrix, just having that pain present is enough to make the perception of that tissue problem worse. And it goes round and round. And then what happens is once you reach a certain threshold of pain, suddenly your sleep is interrupted. Okay, so now your sleep is interrupted, your pain is going to be worse. Suddenly you're down in the dumps because this pain is preventing you from doing what you want to do. Okay, so now the pain is worse, you're more depressed, and it goes round and round like that. So it's really about putting an end to that cycle and trying to kind of wind it around in the opposite direction. I'm going to take my water break now and hand over to Dr. Robinson, who's going to start talking about the specific individual treatment paradigms. And I'm looking at the clock, and it's 5 to 3. I don't know if now is a better time to take a break so that we can go into a new topic, or we can carry on. We're happy to talk about this for hours.
Slide 39.
We're halfway.
A little over halfway.
Yeah,
How long would you be on this second part?
a long time.
There's no part of it that you want to do it.
My part is shorter than Tanya's longer.
Yeah, yeah.
You want to take your time?
Yeah, I think now is a natural break rather than a slide that is not a natural break. Okay, thank you. We'll be back in a bit.
Thank you. Okay, so we will take about a 10 to 15 minute break.